Let's dive right into part 4 of our explainer on the urine chemical exam. Today, we're zeroing in on our absolute primary and arguably most vital tool in the lab, the reagent strip. If you're looking to really lock down the chemical analysis of body fluids for your exams or your clinical practice, well, you're exactly where you need to be. But hey, before we start pulling our first chemical clues, let's just take a quick step back. Remember we just wrapped up proper collection methods and physical characteristics? Color, clarity, specific gravity in our last explainer? Those physical observations, they perfectly set the stage for what we're about to test chemically. For example, a pale urine with a suspiciously high specific gravity might actually be your very first hint at what we're going to find when we test for glucose in a few minutes. So here is our roadmap for today. We're going to systematically break down reagent strip fundamentals and then hit the big 4 early analytes: pH, protein, glucose, and ketones. Let's start right at the beginning. Section 1, reagent strip fundamentals. Okay, so reagent strips are basically chemical impregnated absorbent pads attached to a plastic strip, and they give us rapid, semi-quantitative readings from negative all the way up to 4+. The absolute key here is mastering your technique. You've got to dip the strip briefly into a well-mixed, room temperature specimen. If it's unmixed, heavy elements like cells just sink to the bottom and you'll miss them. If you dip it for too long, the chemicals actually leach out into the urine. And if you don't blot the edge on an absorbent pad, you're going to get pad runover, which completely ruins your results. Finally, always read it in good light, holding it near, but absolutely never resting directly on the color chart. We do not want cross-contamination. Now, these little pads are incredibly sensitive. You have to guard them against the 4 main causes of premature deterioration: moisture, heat, light, and volatile fumes. Keep them stored under 30 degrees Celsius in an opaque, tightly sealed container with a desiccant. And for quality control, you must run both positive and negative controls at the start of every shift, every 24 hours, or whenever your results just look questionable. Oh, and here's a massive clinical pearl for you. Never, ever use distilled water as a negative control. The chemical reactions on these strips are specifically designed for the ionic concentration of urine. Moving right along. Section 2, pH and acid-base indicators. As we know, the lungs and kidneys regulate our acid-base balance, which gives us a normal urine pH range of 4.5 to 8.0. The average is usually around 6.0. A first morning specimen will typically be a bit acidic, around 5 to 6, though it can swing alkaline after a big meal. That's called the alkaline tide. But what if you dip a strip and get a pH of 8.5 or 9.0? Hard stop right there. A freshly voided urine simply cannot reach a pH of 9.0. If you see this, it means the specimen is old, urea has been converted to ammonia by bacteria, and you have to get a recollected sample. It's totally invalid for testing. In this graphic brilliantly shows exactly how the strip measures pH. It uses a double indicator system. Because we need to measure a massive range from 5.0 to 9.0, one single chemical just doesn't cut it. Methyl red grabs the acidic 4 to 6 range, shifting from red to yellow. Then bromthiamyl blue takes over for the alkaline 6 to 9 range, going from yellow to blue. This is literally the fastest reaction on the entire strip. You read it instantly. And the best part? There are absolutely no known interfering substances for the pH reading.
All right, Section 3, protein, the renal flag.
Elevated protein is, hands down, the most important early indicator of true renal disease. Normal urine has less than 10 milligrams per deciliter of protein, and it's mostly albumin. When we see proteinuria, we classify it into 3 distinct categories based on its origin. Just remember the mnemonic: pre, renal, post. Pre-renal means the issue is in the plasma before it even hits the kidney. Renal means actual glomerular or tubular damage, or even benign things like orthostatic proteinuria, where protein only shows up when the patient is standing up. And post-renal, that means the protein was added lower down in the tract, like from an infection or menstrual contamination. Now this next one is wild. Bence-Jones protein. This is a classic pre-renal condition linked to multiple myeloma, where monoclonal light chains just overflow into the urine. It has a super testable, totally fascinating physical property. If you heat the urine, this specific protein coagulates and turns cloudy right between 40 and 60 degrees Celsius, but then it magically redissolves and clears completely up when you hit 100 degrees. So how do we actually test for protein? The reagent strip uses the protein error of indicators principle. The pad has an indicator dye and an acid buffer that locks the pH right at 3.0. When protein is present, specifically albumin, it accepts hydrogen ions from the indicator, shifting the color from yellow to green or blue. But you've got to be careful. This strip is way more sensitive to albumin than to globulins. Also, routine strips aren't sensitive enough to catch microalbuminuria, which is a major early risk marker for diabetic nephropathy. You need specialized testing for that. Oh, and watch out for false positives if a patient has highly buffered alkaline urine or quaternary ammonium detergents in their sample. That will override the acid buffer entirely. Because the strip can miss other proteins or throw false positives, we rely on a confirmatory backup test, the sulfosalicylic acid, or SSA, cold precipitation test. Here you can actually see what this looks like in centrifuge tubes graded from negative up to a thick 4+. Unlike the strip, the SSA reacts equally with all forms of protein, including that Benz-Jones protein we just talked about. But again, watch your interferences. Things like X-ray contrast media and massive doses of penicillin can give you false positives on the SSA.
Next up, Section 4, Glucose and Sugar Thresholds.
Testing for glucose is actually the most frequent chemical test we perform on urine, mostly to screen for and monitor diabetes mellitus. Usually, every bit of glucose filtered by the glomerulus is actively reabsorbed in the proximal convoluted tubule, meaning glucose really shouldn't be in your urine. But the moment blood sugar crosses the strict renal threshold of 160 to 180 milligrams per deciliter, tubular reabsorption just maxes out. The excess sugar has literally nowhere else to go, so it spills into the urine, which is a condition we call glycosuria. To spot this, the strip uses a double sequential enzyme reaction called glucose oxidase. Pay attention to the distinction here. This reaction is highly specific to glucose in glucose alone. Strong oxidizers like bleach can cause a false positive, while unpreserved samples undergoing glycolysis and cause a false negative. But we also have a backup called the clinitest, which uses copper reduction. The clinitest detects all reducing sugars, galactose, lactose, fructose, you name it. Now, even though the clinitest is technically less sensitive than the strip, it is absolutely critical for newborns. Why? Because if a baby has a metabolic defect causing galactosemia, the highly specific glucose strip will read totally negative, but the clinitest will catch the galactose. Knowing the difference between these two tests can literally save a child's life.
And finally, Section 5, Ketones and Fat Metabolism.
Normally, your body burns carbs for energy. But in situations like diabetic ketoacidosis, starvation, or severe vomiting, the body can't use those carbs and switches to metabolizing fat instead. This process cranks out 3 intermediary products known as ketone bodies. Look at how these are distributed, though. Beta-hydroxybutyrate makes up a massive 78% of the total ketones produced. That's followed by acetoacetic acid at 20% and acetone at a tiny 2%.
And that brings us to a huge clinical pitfall you absolutely have to know. The reagent strip relies on sodium nitroprusside to detect ketones. But get this, that chemical reaction measures acetoacetic acid only. It completely misses that giant 78% chunk of beta-hydroxybutyrate. So in severe diabetic ketoacidosis, where beta-hydroxybutyrate is the main player, your strip reading might severely underestimate how ketotic the patient actually is. Labs will sometimes use backup acid test tablets, but you really have to keep the limitations of your primary strip top of mind.
Okay, let's wrap this explainer up by locking in these high-yield takeaways. The pH is read instantly using a double indicator and has 0 interferences. The protein strip loves albumin, but the SSA backup catches everything. The glucose renal threshold is solidly at 160 to 180. The ketone strip totally misses beta-hydroxybutyrate. And lastly, here is a massive point for both your exams and the bench. Ascorbic acid, everyday vitamin C, is a notorious troublemaker. If a patient is taking high doses, it acts as a strong reducing agent and will cause dangerous false negatives for both your glucose and your ketone strip reactions. Keep an eye out for that one. We've built an awesome foundation today, but think about this. How does a tiny piece of plastic manage to reveal that a patient's liver is quietly failing, or that they have a hidden systemic bleed going on somewhere? We're going to uncover exactly how the strip detects blood, bilirubin, and bacteria in our next explainer. See you then!